Hello, everyone. Thank you for coming. Welcome to this session of NAUTO's 36th Annual Conference. We will be starting in about 1 minute. Before we begin, we want to cover a few housekeeping items. On your attendee screen, you will be able to enter comments and questions in the audience chat. We hope you will take advantage of this opportunity to engage with our speakers. This session is being recorded. The recording will be available in approximately 1 day by returning to this session in the agenda. We recognize and thank our Petabyte sponsor, the California Healthcare Foundation. All conference sponsors have virtual booths available during the conference in the sponsors section. At the booths, you can learn more about the sponsors, review materials, request contact, and collect game tokens. We hope all attendees will take a few minutes to visit each sponsor's booth. During each conference session, watch for a game token that you can collect for a chance to win a grand prize worth $250 or one of several prizes worth $50. Now I will turn the stage over to Norm Thurston, NAUTO's Executive Director, who will start today's session. Norm, you have.
Thank you, Marin. My name is Norm Thurston. I'm the Executive Director here at NAUTO. I'm pleased to be moderating today's session. Today, we're going to be talking about state work on telehealth. We have with us guests from Maryland and from Maine, and we will start with Maryland. So I'm going to go ahead and bring to the stage with me, Melanie Cavaliere. Hey, Melanie, how are you?
Great. Thank you, Norm.
Well, why don't we get started then? Tell us a little bit about yourself and about Maryland's approach to telehealth.
Okay, so first I want to thank the meeting organizers and the attendees. My name is Melanie Cavaliere, as Norm mentioned. I'm the Chief of Innovative Care Delivery at the Maryland Healthcare Commission, and I have over 25 years of experience in the healthcare industry. So MHCC is an independent state regulatory agency. We believe that telehealth is an important strategy to improve access to care and reduce healthcare costs. One agency priority is promoting and diffusing health information technology, including telehealth, among healthcare providers.
So can you tell us a little bit more about what MHCC's role is specifically with telehealth?
So MHCC's role is to assess barriers to adoption and propose solutions, foster technology adoption and meaningful use, and educate providers and consumers on value and best practices.
So some of our audience may not be entirely familiar with telehealth. What are some of the ways that telehealth gets implemented?
I think we need to advance one more slide. Thanks, great. So telehealth can be used to deliver care in a variety of manners. Some involve direct connection to a patient, such as live video or remote patient monitoring. Store and Forward is used to support care delivery. One example is care radiology, where a provider sends an image to a radiologist who reviews and sends their findings back to the provider. Mobile health is a subset of telehealth, referring to the use of devices such as smartphones, tablets, and wearable devices.
So is telehealth a new phenomenon in Maryland, or maybe just give us a little background on how telehealth has developed in your state?
Yeah, so telehealth isn't new. It has been around for many years. In 1906, the inventor of the electrocardiogram published a paper on the telecardiogram. It's been used in radiology for at least 60 years. And since the 1990s, teledermatology has shown high rates of agreement and diagnosis made in person versus virtual. In Maryland, private payers have been required since 2012 to cover telehealth in the same manner as in-person visits. However, there have been changes in response to the public health emergency that I will cover in more detail later.
Yeah, speaking of that, so what did telehealth adoption look like prior to COVID-19? So what was the kind of the status quo before everything got changed?
Yeah, so if you look at this chart, you'll see that there was a difference in the different areas. So hospitals were at 91%. Home health agencies at 27, and practices at 11, and nursing homes around 9.
And then what happened when COVID-19?
Yeah, so big changes, right? It really changed the way that care is delivered as providers sought ways to reduce the spread of the virus and support the social distancing guidelines. We saw rapid telehealth diffusion as a result of the regulatory changes around patient privacy and reimbursement. So the hospitals increased to 100%, and one hospital system reporting having 100,000 telehealth visits in May and June, up from 100 the prior month before COVID-19. Practices increased to 70%, nursing homes to 75%, and home health agencies doubled to 53%.
Yeah, I don't think any of that's really surprising, but it is remarkable, right? To think that
right, yes,
such a big impact, right?
100,000 visits. That's a lot of visits, up from 100. Yes.
Yeah, that's a pretty big percentage year-over-year change. So there had to be some policy changes as well in Maryland. COVID-19. What was happening in the policy arena to make this happen better?
Yeah, so at the beginning of the public health emergency, the government and private payers expanded coverage. So some of those expansions included patient location, where there was a lessening of the geographical restrictions. So they didn't have to be like, for example, in Maryland, prior to the pandemic, the doctor had to be in the state and the patient had to be in the state. After that, it was expanded so that doctors could practice across state lines. So that's also in the next bullet, the licensing. The patient-provider relationship, traditionally it had to be an existing patient, but post-pandemic they were allowed to establish new patients that way as well. The list of eligible provider types was expanded, as well as the type of services that could be covered. Cost sharing was either eliminated or reduced, and the technology was permitted. So they allowed things such as Apple FaceTime and other things, Skype, that were familiar to people but weren't necessarily HIPAA compliant during the public health emergency.
Yeah, so it looks like a lot of this could be done without the involvement of the legislature, but I understand that the Maryland legislature did have to weigh in on some issues. Can we talk just a little bit about some of the things that the legislature did?
Yeah, so during the 2021 session, Maryland passed legislation to keep in place the expanded telehealth policies through 2023. And they included a provision for a study to determine the impact of telehealth, which we'll talk a little bit more about.
Yeah, let's get into that a little bit. Tell me a little bit more about this study. What is it supposed to accomplish? And let's talk quite a bit about it.
Yeah, so it is chapters 70 and 71 of the 2021 laws of Maryland, called the Preserve Telehealth Access Act of 2021. It requires MHC, in consultation with other state agencies, to report on the impact of providing telehealth services, taking into consideration both audio only and audiovisual technologies.
And so what are some of the objectives of this big you're going to do?
Yeah, so we're going to be conducting quantitative and qualitative research on telehealth with the focus on audio only and audiovisual for somatic and behavioral health interventions. So a findings report is due to the Senate Finance Committee and the House Health and Government Operations Committee by December 1st of 2023, with recommendations on coverage for telehealth services and payment levels for telehealth services relative to in-person care.
Okay, so you've got about 2 years to finish this. What are the deliverables going to look like in this study?
Yeah, so there are several deliverables. They include 6 telehealth research and briefing papers on the following themes: disparities in access, the take-up rates, patient-centered care, new models of care, appropriate uses that could substitute in-person care, and equivalency to in-person services. It's going to include an analysis of claims data, a provider survey, and consumer focus groups.
Great. Well, let me take a quick second here and remind our audience that they can submit questions and comments through the chat. Be social, pretend like it's your own personal social media, and say great, good job, or whatever. But more importantly, ask us questions so we have some things we can help fill in details. But let's go ahead and talk a little bit more then about Maryland's telehealth initiatives, because telehealth, the pandemic is its own thing, but there are some important MHCC telehealth initiatives. So let's go ahead and talk about some of those.
Yeah, we've actually been providing grants since 2014. So MHCC has many telehealth initiatives that consist of activities that provide technical support to practices to support implementation, foster peer learning about best practices, assess the effectiveness of select use cases in various settings, and build awareness about the utility of telehealth. So one of them that you have pulled up is the TRA tool, which we developed. And we actually developed a paper version of this in 2018, and we developed an online version, and we were just getting ready to launch it at the beginning of the pandemic. So I'll tell you more about this tool. So it's an easy and practical way for practices to determine the readiness for telehealth. It does this by guiding the user through a self-assessment questionnaire, by scoring responses associated with key readiness areas, and then presenting guidance and information that can be used by practice to improve their understanding of telehealth readiness and actions they can take to ensure successful implementation. One important factor of the TRE tool is that we aim to make it relevant not only for practices that are currently using telehealth, but also for those who are looking to improve delivery of telehealth services. And I'm going to pause for just a second. We have a question from Sylvia Hobbs. Will the report also encompass the telehealth needs of the Department of Defense and military populations deployed abroad? So that question would be for federal telehealth, and we're focusing on Maryland, so we would not be covering those in our report. Thank you for the question.
Yeah, but that is a good point, right? Because Maryland does have a fair amount of military, and they're deployed, and they need that continuity of care. So hopefully the VA and other systems will figure that out. All right, let's talk a little bit more then about this readiness tool. So not every practice is necessarily ready, and this tool will help them figure out if they're ready or what they're missing to be ready. How did you develop this?
Yeah, so there were several steps that were included in the development. We developed concepts and key concepts that were associated with telehealth readiness. We developed questions and scoring methodology using an approach to minimize the bias and maximize validity and reliability. We drafted the supporting guidance documents. We conducted field testing and stakeholder reviews to ensure that questions and scoring are appropriate and that the tool is usable and appealing. Also important was the consideration of the design features and requirements for functionality and navigation, including web survey best practices and optimizing for use on mobile devices. We have another question that was someone from Minnesota who was asked to connect with me, and I'd be happy to. My information is a couple slides from here, so it has my email, and I'm happy to connect with you and talk about this.
You have another question. You can comment through on the screen. So Helen asks the following question. Let's see if we can get it up so you can read it. Do you need any specific skills to support such a concept? In other words, do the practices, do they need people who have an IT background? Do they have to have a clinical background? Or what's your experience? What kind of skill sets are needed to be able to implement telehealth at a clinic level?
So honestly, I think we've seen quite a range. On a couple slides, we'll be talking about a program that we did for practices that included 118, that included some technical support. So, I would say the majority of practices are able to implement it. I think that some EHRs are easier to implement with others. They have basically modules you can kind of plug in for telehealth. I do think the vendors are trying to make it easier for the practices to implement those. I'm happy to reach out to you separately and give you a little bit of information about my experience. We have a report online about the program that I'm going to talk about later, the grant. But I think overall, it is relatively easy for practices to implement on their own. This TRA tool, it's completely free and easy to implement.
Yeah, and you also have a virtual resource center that's been around for just maybe a little over a year. Can anybody use that, or who is it designed for?
Absolutely free. It's designed for providers and consumers. There's a multitude of topics here. We did start rolling it out at the beginning of the pandemic. Several articles, everything on the MHCC website is free.
Okay, and then supporting for vendors. You're also supporting vendors. You get a lot of stuff going on.
Yeah, so we created this vendor portfolio, and this may help a little bit with Helen's question. We worked with stakeholders So we are completely neutral on who a practice decides to implement as a vendor. But we went through and we just compared some of their features, including the usability ratings and the reviews by users. So there's over 70 HIPAA compliant vendors in there, and it's an interactive Excel workbook. So if you go in there and download it, you're able to answer the questions and try to get one that might match up with what you're looking for.
Okay, and our last topic for you is the Telehealth Expansion Grant. How did that work? Did you like it? And would you do it again if you had the money?
Yeah, so this turned out to be really excellent timing. We used 3 state designated MSOs to assist small practices with telehealth implementation. They helped practices with telehealth technical requirements, clinical best practices, and policy developments in response to COVID-19. So the next slide shows some of the accomplishments, which were the grant concluded in 2021, and we did help 118 practices with adoption.
Well, that's fantastic. Well, thank you for taking time, Melanie. We're delighted to have you. And like Melanie said, there's her email address, there's the website. Feel free to reach out. She'd be happy to share Maryland's learning knowledge with you. Charles, let's go ahead and bring our friend. We got one more question before we go. How well did the telehealth work in nursing homes? Did the elderly like that?
Yeah, so I actually think in some cases it worked very well because they didn't have to move the patient to take them to the doctor's visit or to the hospital. So nursing homes was actually one of the early pilots that we did. Usually when it's in the nursing home, the person conducting it is, obviously a staff member. Some of the practices did have a little bit more of a struggle with implementing telehealth with some of the seniors because they weren't as familiar with using computers or their phones to show different angles and things like that.
Okay. We do have more questions, but we don't have more time.
Okay, that's fine.
We will ask people to reach out directly to Melanie and ask those questions. So Charles, could you go ahead and bring our friends from Maine
so
to the stage? Thank you, Melanie. All right, so we have with us Kimberley Fox and Yvonne Yonk from University of Southern Maine. I was going to say South Maine. I knew that wasn't right. So the University of Southern Maine. We're glad to have you with us to talk about Maine's experience in telehealth. And this is, again, a little bit of a different twist. So let's go ahead and get started on that. All right. Right off the bat, why don't you tell me about the context? What is it about telehealth in Maine that really kind of gets everybody excited?
Well, I think that I wanted to give people a little context of what Maine looks like in terms of rurality, because even before the pandemic, we were definitely concerned that rural Maine children face greater barriers in accessing needed services, given the limited supply. Many of them live in medically underserved areas. And telehealth provides a clear opportunity. You can see, obviously, in this map, there's certain areas of the state that are extremely remote and really don't have access to providers. So telehealth provides an opportunity to get needed healthcare, developmental and behavioral health services to children living in these underserved areas. And so we were undertaking a study that was funded by actually the University of Maine Rural Health Wellbeing Challenge Grant, and supported by data provided by the Maine Health Data Organization to investigate children's telehealth use and barriers, to inform research and training programs, and also to assess the impact of policy change in the state. Pre-pandemic, like Maryland, Maine had passed many telehealth supportive policies to encourage greater telehealth use in the rural areas of the state, particularly in the Maine Care program, which is Maine's Medicaid program, as well as in coverage changes, requirements on commercial insurers, like coverage parity even back in 2009. And then during the COVID pandemic, Maine Care insurance and telehealth coverage further expanded to address, obviously, the public health emergency and even reduced access to in-person care. Maine Care expanded audio only and allowed more providers. Many of the policy changes that Maryland also we took in Maine. In the insurance rules for commercial insurers, we added audio in-person coverage and payment parity. So all of those things were things that we would expect to see changes potentially in use. And so the goal of our analysis was really to assess how those telehealth policy changes affected children and adolescents' use of care and whether it helped address gaps in care to rural kids in particular.
So it was interesting before the pandemic, but the pandemic just made it a whole lot more interesting. Is that fair to say?
Yeah, well, I think that these slides will show you that that's why we looked at the pre-pandemic. There were telehealth policies in place that one might have assumed that there would be probably more telehealth use prior to the pandemic, but you can see this huge increase that occurred in the 2020 because of the expanded policy changes during that period.
So,
I did just want to say, because we didn't say it, that this is based on data that we looked at in the Maine all-payer claims database from 2014 to 2020, and we isolated the claims, the telehealth claims, to specific use modifiers to identify telehealth within the claims, and we defined telehealth users as anybody who had any telehealth claim during that period. So this slide basically shows the trend in use, and you can see that while it had been increasing gradually up until 2019, children's use of telehealth was still relatively low, only at like 1.8% in 2019. But then it jumps up significantly, and the jump, as you can see, is really across the payers. But obviously still driven largely by Maine Care, which had been the case prior to COVID. And the slide on the right here shows the quarterly change overall, and consistent with national trends that we've seen in other data. There was that huge uptick in the second quarter when many of us went remote and the in-person offices were closed. And declined somewhat in the third and fourth quarter, but you can see it's still like significantly higher than what had been in pre-pandemic period.
So do you think these changes are permanent, or is it when the pandemic ends, is it going to go away? What do you expect to happen?
That's a good question. I think that's what the state is grappling with now in terms of extending policies. There are a few policies that Maine Care has continued to extend. In the commercial sector, it's unclear what the regulatory requirements will. Technically, the COVID changes in telehealth policy for commercial insurers ran through the state's public health emergency period, which ended at the end of June. So it will be important, I think, to continue to track, claims related to telehealth over time to see whether once those are that go away, whether telehealth use will persist.
Okay, and looking at this chart that you guys have provided, I can see that, like, for example, Q2 of 2020, there's this huge shift to telehealth, but it looks like that children didn't quite make up the full gap. Do you want to comment about, the total services and the ability of telehealth to fill that gap?
Yeah, during the public health emergency, as seen nationally as well, there was a decline in new use overall by kids. And that's what this slide is showing us. But the telehealth certainly helped maintain a lot of access up to prior levels of service use, but it was not able to maintain it entirely. It helped, but the trend still is a declined service use overall.
Okay, let's take a look at another graph here. This is maybe my favorite one of all the ones that you provided. What are these children using telehealth for? What types of services are best suited to telehealth?
Well, prior to the pandemic, kids were primarily using it for speech language pathology and behavioral health services. I would say that they were probably equally distributed in rural and urban areas. But then going into the pandemic, the increase was largely in the behavioral health services and also other, which even though we don't have it here, other is inclusive of actually behavioral health related services, including targeted case management for kids with serious behavioral health issues. So it reflects that the vast majority of services being provided during the emergency were for behavioral health and mental health services.
Okay, and by the way, as you can see on the screen, the game token for this session is the word behavioral. And if everybody wants to just click on the game right over there, you can drop that token in and get a chance to win some fabulous prizes. And the way the platform works is that you won't actually disconnect from us. You'll be able to keep watching us while you do that, but we'll keep moving forward. All right, so let's talk about a little bit more then. Who's using telehealth? I guess, is there anything that we didn't cover on this slide that you want to cover?
Well, this one I think was just alluding to, because Melanie, when she was talking about change in provider use in Maryland, I thought it was beneficial to also see in Maine for the providers that provide services to children, that the obviously huge increase in adoption of telehealth corresponding with the things that we're seeing on the service side, and the number of providers increased, tenfold or more, 15-fold. In 2020, which is a good sign that it's being more broadly used across a variety of providers.
Okay.
And then I think I'm going to hand the rest over to Yvonne to talk about the characteristics of the children using.
Yeah, because you guys did a fancy logistic regression study, with really complicated study here, and so let's get into that. Let's bring Yvonne to the forefront here. Yvonne, tell us a little bit about these characteristics of the children using telehealth relative to children not using telehealth, comparing 2018 and 2020.
Thanks, Norm, and thanks, Kim. So this slide, as Norm was saying, illustrates who's using telehealth, and we're comparing 2018 against 2020. So the pre-pandemic period, we actually had in the logistic regression, you'll see we included the years 2018 and 2019 and called that the pre-period or pre-pandemic period. And during that time frame, telehealth users were more likely to be covered by Medicaid. So you see the highlighted red statistics there. I was hoping that would help because it's a rather busy slide, but telehealth users were more likely to be covered by Medicaid, be older, in the age groups of 7 through 12 and then 13 to 18, more likely to be male, and live in more remote rural areas. So you see small rural and isolated small rural areas. Those were determined using the rural urban commuting area codes. So they were more likely to live in these more remote rural areas than children who didn't use telehealth. Telehealth users also tended to be sicker and in the higher health risk categories, as indicated by the higher resource utilization bands, we call them RUBs, and those are in the lower portion of this table. So you see the low utilization, moderate, high, the percentage of children falling in those categories were higher for telehealth users versus non-telehealth users. So, that speaks to the importance of telehealth in terms of accessing services that were needed by populations that needed them, those services. So while many of these characteristics held true during the pandemic, which is in the year 2020, we did see a few important shifts, and those shifts were that in that kids covered by commercial insurance accounted for a fair share of telehealth use during the pandemic. Still, Medicaid was the primary payer, but you did see an uptick in the percentage of children who were covered through the private sector who were also using telehealth. And we also saw that a higher percentage of telehealth users were in urban and large rural areas during the pandemic compared to before the pandemic. And so the small and isolated small rural areas experienced relatively lower rates of telehealth use during the pandemic compared to where things were before the pandemic. So we're going to come back to this point in the next slide. So you can move to the next slide. So in this, sorry, go ahead, Norm.
Oh, yeah. So I was just going to kind of comment before we move on. Let me just back up one step here. So what it looks like what's happening then is that the pandemic caused telehealth to kind of catch up, if you will, in some settings. So such as in the commercial setting where it was lagging behind, or in the urban setting where it's maybe lagging behind. Is that a fair characterization of what's going on here?
Yes, absolutely. So we saw that commercial accounted for 5% coverage of children using telehealth in 2018, where it accounted for almost 30% or a third in 2020. And then we saw that shift, there was a decline actually in the percent of children not in the numbers, but in the percent of children using telehealth in small rural and isolated rural, and then that uptick in urban areas. So yes, definitely catching up.
So it wasn't like it was less, like we're not decreasing. In fact, I don't think anywhere it's decreasing. It's just increasing in some of the areas that were a little bit behind. Okay, let's go ahead and move on to the next one then. These are results from your logistics regression, right?
Yes, right. So what we did in this slide, I mean, in these analyses, were to essentially identify risk factors for using telehealth. So we were able to confirm that the likelihood of using telehealth was higher during the pandemic, obviously, compared to 2018 and 19, for those children in the higher health risk categories. So we see the RUBs 3 through 5 in this diagram. So for example, the odds of using telehealth were 75 times higher for those in the highest risk category than those in the lowest risk category, which is essentially the kids who are healthy. And then we saw the likelihood of using telehealth was again higher, like we saw in the descriptive analysis, for the older children, age 7 through 12, 13 through 18, compared to the preschoolers. And then for children on Medicaid. But then since we saw this shift in the use of telehealth from small and isolated small rural areas to urban and large rural areas in the last slide, we included an interaction term for rural and time period. So the time period was really sorting out what was going on in the pre-pandemic period versus during the pandemic in 2020. So we included this interaction term so we could capture that shift in the use of telehealth across geographic areas. So what we found was that in the pre-period, the odds of using telehealth were 1.4 times higher in small and isolated small rural areas than in the urban and large rural areas, which were our reference group. So within the urban and large rural areas, the odds of using telehealth were 23 times higher during the pandemic versus the pre-period. So you see that in terms of the odds ratio.
So in the pre-post, you basically see it going up everywhere.
Yes.
None of these factors are negative. Now, we do have a question about the data here. The Maine APCD, I'm just going to phrase this slightly differently. Does Maine's APCD capture denials? Do you know if that is available in the data?
I can answer that if you want. I mean, it is in the data. This data reflects adjusted claims. Our analysis is post-adjudicated. Yeah.
Yes.
Okay. So I think this is maybe something to look in later and to see if there were telehealth claims that were being denied and what were the reasons for that not being denied. That's something that Helen could follow up with you later, I suppose. Okay, let's talk a little bit then about policies. What are some of the policies that they suggest to you? Policy implications, next steps. What do we need to be thinking about going forward?
Yeah, I think that the results of this work definitely suggest that telehealth policy leniencies during the PHE really help children maintain access to the services. And even though it did not offset the overall decline, it certainly made up for some of that decline. So I think it shows a positive impact of those policies. And the fact telehealth does appear to have helped primarily maintaining access for the highest need children is really positive news. I think the relative increase in the use of telehealth among children living in the large rural and urban areas compared to the more remote rural locations, may be indicative of barriers to expanding telehealth in rural areas that are not policy specific. I mean, the rural communities, I think, may have had a harder time adopting if they were not necessarily part of large health systems, et cetera, that have systems in place to come. And also there's broadband issues in rural communities that could have affected their use during the public health emergency. So we plan to do additional analysis to assess the impact of specific telehealth policies, if that's possible, to be able to isolate which policies were most effective. We know from other work that audio was an important component to a change in policy, to allow for rural access, especially given broadband issues. So we want to, for future analysis, to really look at those potentially policy-specific impacts within the data. And Yvonne, I don't know if there's anything else to add.
Yeah, I just wanted to say that, that interaction term had the odds ratio was lower than 1. So what that meant was that during the pandemic, the expected increase in the use of telehealth in rural was lower than it was in urban. And so we think that shift was really, as Kim was saying, was really because of the barriers to implementing telehealth in rural areas, such as the lack of broadband or internet access. So in other words, urban areas were better positioned to make that transition from in-person to telehealth during the pandemic. And they were able to take advantage of the lifting of the restrictions to using telehealth. We think in part because of better connectivity.
Well, great. Well, we want to bring back Melanie to the stage. So thank you all. I want to recognize Milliman Med Insight, who has sponsored this session, and they've in fact sponsored our entire Igniter series. We are glad to have them as our sponsor. The recording of this session will be available in about a half an hour. So anybody who has friends, or if your colleagues missed it, you can come back in about a half an hour and watch this again. Or if you missed the token, you can come back and fast forward and find the token. But we're excited to have everybody here. We're looking forward to tomorrow, our pre-conference forum and the pre-conference symposium. Hopefully everybody can join us and bring a couple of friends. So with that, thank you, and we'll see you all tomorrow. Thank you, everyone.
Thank you very much.
Thank you.
Appreciate it.